We will have an engaging panel discussion on the father, the son, the brother, and their mental health, trends in male mental health, with Dr. Vaughn Gay, Executive Director of Holistic Atlanta, and Vaughn Mosher, the Managing Director of Benedict Associates Limited. If this is a topic you're here for, please stay with us in this particular room, and I'll introduce Dr. Vaughn and Vaughn. Yes, they have the same names to lead through this insightful discussion.
At Family Center, we know it takes courage to seek help. We are here to provide therapeutic support to families with children ages 4 to 18 to facilitate healing, hope, and connection so that families and children can thrive. Family Center helps children and their families with aggressive or acting out behaviors, difficulties with impulse control, adjustment challenges, symptoms of anxiety and depression, symptoms of trauma, grief and loss, school issues, social issues, and relationship challenges. Contact us at 232-1116 or email info@tfc.bm. Our services are free and completely confidential. If your child needs emotional or social support, call us today. Please do not suffer in silence. We are here to help.
Okay, so introducing Dr. Vaughn N. Gay, a licensed professional counselor and a mental health advocate. He is the founder and executive director of Holistic Atlanta, a healthcare company specializing in virtual health and telemedication to enhance mental health in underserved communities. Dr. Gay's office offers clinical psychotherapy and has conducted seminars and wellness programs for top corporations, including the Atlanta Hawks, Chick-fil-A, NFL, PA, and academic institutions like Georgia Tech and Emory University. His global work extends to collaborations with organizations in Haiti and Bermuda. I would like to present Dr. Vaughn Mosher, a seasoned professional with a wealth of experience. He's been the managing director at Benedict Associates Limited since 1986. Vaughn holds two master's degrees, one in social psychology and another in mental health. I cannot. I'm gonna have to let him clear that one up for me. Epidemiology,
Epidemiology.
and public health administration. He's a certified executive and life coach and offers coaching services for work-related and personal challenges. Vaughn has also contributed to community affairs for over 25 years, and he serves on various boards and is an integral part in the Employee Assistance Professional Association, a global leader in EAP services. So, welcome to the stage, you guys.
Thank you, Jody.
Thank you so much for the introduction, Jody.
I'm going to start off. And you're going to hear from each of us, and then we'll have time at the end for discussion. So here's the layout. I have to talk faster than I usually do because I've timed this, and I want to be able to say everything that I have put down here on paper for us. Mental illness and mental health can be affected by a number of factors: demographics, country of origin, gender, race, age, and all sorts of things. And what this session is going to focus on specifically is, broadly, is gender. So this hour will be divided broadly into three sections. Obviously, I'm starting it off with positioning male mental health, mental wellness issues in the context of international data for the first 20 minutes. Following myself and positioning this globally, we'll hear from my colleague, Dr. Vaughn Gay, who will be talking about some of the unique solutions featuring in his practice in Atlanta. And I'm excited to hear a lot more about that. And then, as I mentioned, the third section will be discussion and considerations about gender and looking at the broader aspects of mental illness and mental well-being for our community as well as the individuals in it. So let's get started. Mental health issues can affect people in all kinds of combinations of gender, And the prevalence of specific mental health conditions can vary greatly between men and women. I've actually found out a lot by delving into this research over the last few months. So it's been more of an eye-opener for me as well. It's important to note that statistics change over time and can be influenced by various factors, including genetics, as well as cultural and societal norms. We have researched global and national data via the World Health Organization from countries Thailand, Japan, Southeast Asia, Australia, Europe, UK, US. We have some information about Bermuda, including academic papers in all of these areas looking at various populations, including studies from hospitals, prisons, mental health settings, clinics, and I even have a few things to say about our own data, not over the last 35 years, but the last 4 or 5 years. A lot of significant global information has ended up on the cutting room floor with me as I decided somewhere along the line that this was not a doctoral dissertation, but rather only an hour's presentation, and I had just 20 minutes of that. So I had to stop and say enough is enough. So here we go with some of the global facts, statistics about men and mental health. It's random. It's if you want to jot anything down that captures you, please do so, and hopefully we can come back to that. For your benefit, I decided not to have slides and to just talk, so there won't be any presentation for you to actually look at visually, just what I say in audio. We do have some information about Bermuda, and this is a plug, and he doesn't know it, a plug for Scott Pearman. Tomorrow, for just at the very end of the close, tomorrow, Friday afternoon, Scott Pearman will be releasing vital and relevant new information in his closing presentation called Acute Adult Mental Health Integrated Care Pathways. And the findings are from a 16-week study and looking at mapping 30 of Bermuda's key mental health challenges in 7 different priority areas. And I'm very excited to hear about that. Part of my frustration in gathering data was that I was able to get information from all over the world, but I was having some significant difficulties in getting information here because we tend to collect information in silos. And I think what we'll hear, I hope what we'll hear from Scott is Bermuda broadly as a total community and as a country. So off we go. The World Health Organization has some key facts in general. Here we go. 15% of working adults are estimated to have mental health disorders. Globally, an estimated 12 billion working days are lost every year to depression and anxiety at a cost, just in the US, the cost is $1 trillion per year in lost productivity. There are ever increasing effective actions to prevent mental health issues, mental health risks at work by promoting mental health under the DEI. And most of you, many of you, probably all of you know that stands for diversity, equity, and inclusion. And now there's a B that's going to be attached to that as well. It'll be, in addition to DEI, it'll be DEIB, and the B is for belonging. As we heard from Annie Richardson, there are great things happening now with what employers can be involved with. Experts generally agree on 5 broad umbrella headings for diagnosing mental illnesses. And needless to say, mental well-being is more than just the absence of a mental illness. So we're looking at this as an entire continuum, and therefore difficult at times to discern in that middle gray area exactly what's what. We know the two ends, if you think of it as a bell-shaped curve, we know definitely what is mental illness and what requires hospitalization. And then the more gray area of perhaps lagging on into flourishing in terms of as good as it can get in terms of our emotional and mental well-being. But the 5 broad areas are anxiety, depression, addictions, trauma, and neuropsychiatric issues. Again, broadly, anxiety, depression, addictions, trauma, and then all of the neuropsychiatric issues that are in the Diagnostic and Statistical Manual that we have in psychiatry. Whereas mental illness is more commonly treated in women, when we look more closely, we would find depression as the number one for women, followed by anxiety disorders, followed by eating disorders, personality disorders, and then post-traumatic stress disorder, as you know, more commonly known as PTSD. In contrast, men tend to have higher rates of substance use disorders and addictions, including process addictions, including sex addiction, gambling, and areas that are not substance related, but rather process related addictions. Next most common diagnosis in men comes under the heading broadly of antisocial personality disorders, and often that's characterized by a disregard for the rights of others. And that's the definition of antisocial broadly. Many professionals might call it acting out. It shows up as anger control or behavioral issues, as it's often the lashing out that is characteristic of what the acting out or behavior might be. Looking more deeply at NIAAA, National Institute on Alcohol Abuse and Alcoholism from the US, a recent study shows that 68,000 men die annually from alcohol-related causes alone, compared to 27,000 women. That's 68,000 men, 27,000 women. And that's a rate of men to women 2.5 times over. Next for men, next to the addictions and substance abuse, we have, next for men, we find schizophrenia. And of course, that's found in both genders. However, it tends to emerge earlier in men and has a higher prevalence in men as well compared to women. Last of all, disorders found in men would be on the autism spectrum, and that's more frequently diagnosed in men than women. With ADD and ADHD, you know that the H makes the difference, and that H is for hyperactivity. That makes it more easily, the H is what makes it more easily diagnosable, and the hyperactivity factor is more common in males. And you can ask school teachers, primary school teachers, about that, and I think their experiential data will concur with what's going on globally. There are 3 males for every female with ADD and ADHD. It's important to note that these gender differences can be complex and involve a combination of biological, genetic, and psychological, as well as sociocultural factors, not to mention sugar. Interestingly, when looking at gender differences in mental health prevalence, when we look at the Journal on Abnormal Psychology systematically, we find indications that, first of all, women show high rates of mood and anxiety disorders, and men show higher rates of antisocial personality behavior, substance use, and we already know that. Those are the 2 big ones for men. And I'm sure we'll hear a lot more about that from Dr. Vaughn Gay from Atlanta. What this research shows in investigations more deeply was a pattern of what's called disordered comorbidity. And that's a fancy 50-cent word for that more things are happening than just one thing at a time. So comorbidity is looking at this, but in a disordered way. We found that the dimensions were distinct by gender, more along the lines of what issues get internalized versus externalized. That is to say, internalizing is characterized by having things be dealt with internally within the individual. For instance, if there's anger, if there is something where anger is thwarted or can't be delivered, that more easily can be turned inward against the self. That would be an example of internalizing anger that would become a depression, or perhaps situational depression or mood disorder. And that's found, the internalizing features are far more prevalent in women. And guess what? Externalizing factors being characterized far more by our male population. Again, antisocial behavior, social aggression, substance abuse. The aggression goes outward into the environment and is externalized rather than internalized. And I think that's a fantastic area for further exploration. And I'd love to know, as an old-time researcher, how that manifests here in our community in Bermuda. So one exception is marital status. Depression actually is more common and more severe amongst men who are divorced. So we have what would seem to be a lot of conflicting data, but not when you get down to the actual studies. Depression is broadly more so with women, but when we look at this, an exception is marital status, and that be for men. There's more depression with men who are divorced. The diagnosis then is based on one's behavior and how people show up rather than what the origin might be. With women tending toward internalizing ways of coping, that shows up as mental illness, and the behavioral manifestation would show up more as the behavior as it shows up in institutions, in the community, in jails, and so on. Whereas men act out or show up with this externalizing feature, that's the antisocial behavior, lack of anger control. We see it in gang violence, and so on. We could have a whole day's conference just on that alone. Both males and females exhibiting anxiety and or depressive symptoms regularly respond similarly to the same pharmacological interventions. That's clear. Likewise, anxiety and depression both respond well to CBT, cognitive behavioral therapy. So both genders react to that beautifully. There have been efforts to develop psychotherapeutic interventions that address these gender-shared factors. However, men are less likely to access such treatment, so that makes a huge difference. Although they may respond similarly, the men don't show up in places where treatment could occur. Looking at suicide, there are a lot of studies that have been done globally on differences in gender for suicide. We find some very interesting gender differences in the prevalence regarding the suicide rates. As women are more likely than men to experience mental health conditions, they also are more likely to attempt, and that's in bold, more likely to attempt suicide. However, men are more than 3.5 times more likely to actually succeed at suicide compared to women. Again, that's an important distinction that first off looks to be confounding, but in fact is very imperative to look more deeply as to attempts versus successful execution of suicide. This may mean that they tend to choose more lethal weapons. Men may choose firearms as their mode of wanting to successfully suicide, and with females it may be cutting or pills or some other method that is less lethal, and it may not be completed, and they may be recovered from or rescued from the suicide attempt. One study suggests that being alone, single or divorced, is a significant suicide trigger amongst men more so than women, and might more likely include other associated factors such as legal or financial concerns around perhaps divorce, and can be triggered more easily with mental health problems, increasing the risk of suicide. Further into the research indicates that around 60% of men experience at least one traumatic event in their lifetime, while only 50% of women experience what's defined as a traumatic incident in their life. Types of trauma differ naturally from men to women, with men being perhaps more likely to experience accidents, assaults, combat, war, natural disasters, and witnessing the death or injury of of loved ones. Women are more likely to experience sexual assault or child sexual abuse. Although men have a higher risk of traumatic events, women are actually more likely to develop PTSD instead, and therefore have anxiety and or depression that manifests around that. So in various parts of the world, there has been some well-executed research worth mentioning. Thailand was found to be consistent over a long period of time. I believe it was 18 years. The data has consistently been culled and looked with the same sorts of parameters. And so they have longitudinal data that is tremendously useful for other countries to model. So Thailand was found to be consistent over a long period of time, as with other countries in Asia and Japan. When we look at gender there, we see men reported lower levels of life satisfaction than females and were less likely to access psychological help compared to women, with only 36%. Only 36% of the referrals from males, meaning that the balance of 100% was from females. In the UK, nearly 75% of missing people are males, and men are 3 times more likely to depend on alcohol and 3 times more likely to report drug use compared to women. Likewise, in the UK, regarding hospital admissions, we find that 20% of the older female population has a diagnosis of depression, whereas it's only 8% amongst males. That's 20% for women for depression and only 8% for males. Also in UK, men are actually 1.5 times more likely than women, 150% more likely than women, to actually be victims of violence, while women are twice as likely, 200%, to be diagnosed with anxiety than men. That's several UK studies. UK studies also found that this internalizing disorder was more commonly found amongst females. So we see global trends here. Once again, externalizing disorders way more common amongst males. So the gender divide is a major factor for internalizing versus environmentally or externalizing that disorder. In Bermuda, late yesterday, I was able to obtain some very significant data based on 5 years of admissions to Maui. And that was from 2018 to 2022 that looked at gender and race. That was one of the areas I had been having difficulty in accessing. And fortunately for Kathy Stubble and her team, they were able to pull data from their actual go-to resources and pull this together for me. I'm very appreciative of that. I don't have data on primary cause for admission, but I do have on gender and race, and here we go with that. Out of 1,680 admissions over those 5 years, males accounted for 61% of the admissions and females 39%. And when we look at admissions by race, you may already have guessed accurately that looking here at MWI, the team found that 79% of the admissions at Maui were amongst the Black population, both male and female, and 19% were white and 2% other. Again, we'll hear hopefully way more from Scott Pierman tomorrow afternoon, but that's a little tidbit of what we do have from Bermuda. Many research projects have been conducted with prison populations over the last 20 years that range from 93 to 98% of prison occupants being male. And we're talking about 11.5 million people globally. And the range, again, is from 93 to 98% globally. Prisons are occupied by males. Africa has the highest rate of males proportionate to females, and that's at the rate of 98%. Oceania, the Americas, North and South America, Asia, were closer to 96% being male. Since 2019, the rate has actually gone down to 93% for male, not because males haven't increased, but because females have increased at a faster rate than males have in terms of being incarcerated. Females increased by 60% over the last few years, whereas males have increased in the prison population by only 22%, 60 female, 22 male for the increase. Of all the continents looked at globally, only Europe was the large geographical area to have the female population in prison actually decline by 13%, where all other countries rose from 60% to 113%. Looking at race in Australia, we find that the rate of incarceration for the Aboriginal population to be 626 times as frequent as non-Aboriginals. In the US, Black men are incarcerated 6 times the rate of non-Black population, and Latino men are incarcerated 2.5 times more frequently than the incarceration of white males. Coming down to the end here. In Spain, 51% of females are in prison. They suffer from anxiety, compared to only 37% of males in prison. And when we look at the general population in Spain, there is only 16% suffering from anxiety. But in jail, 51% of females, and in jail, 37% of males in prison. Also in Spain, women had a far greater prevalence of personality disorder and depression compared to men, while males had a much higher rate of schizophrenia than the women. In summing up, understanding mental health data within the context of each jurisdiction's population's needs will allow us to deploy resources for vital services more appropriately for better outcomes, and at an earlier point in the progression of specific mental health issues. According to the World Health Organization, the risk factors can manifest naturally at all stages of life. However, the developmental period of life is especially detrimental. Examples such as harsh parental physical punishment and bullying are especially leading in the risk factors for problems later in life in mental health areas. Protective factors also occur throughout life and strengthen resilience from childhood through adulthood. Early focus on social and emotional skills delivered in a safe environment with community cohesion are elements for very significant protective factors. Protecting mental well-being at work has more recently become a higher priority, and you just heard that with our first speaker this morning. I didn't know that was coming, and so this reinforces what we've all heard up close and personal from Annie Richardson. So it's much more a much more appreciated domain to be effective for impacting positive change. In so doing, we shift the focus for treatment, as the treatment being the sole focal point, to earlier intervention that can occur in the workplace for both intervention and schools and work for prevention. Efforts that are also likely to increase emotional literacy early on in life, both in school and at home. And now to some significant information shared by Dr. Vaughn Gay. And remember, again, tune in tomorrow afternoon for Scott Pierman's presentation after, I guess it's around 4:15, something like that. Thank you.